So welcome to the first video of a multi-part series of ENT lectures. Today's topic is common ENT emergencies. Now this is set at an SHO level and should hopefully be helpful for those of you, be you an F2, an GP trainee, a core trainee, or a trust grade starting ENT for the first time, or if you're a bit more experienced and coming back to ENT after a rotation away, this might serve as a good refresher course. What I'm going to touch upon is general emergency advice that you have in an emergency, then kind of narrow it down to the a bit more common ear, nose and throat specific emergencies, and then touch on some tips for medical students, how they can make the most out of their placements when they're rotating within the speciality. Just a word of warning, I'm not going to go full into depths of every single ENT emergency. It's more of a guide, so please be prepared to do some more reading for the various ones. So in a general emergency, it's very important that you feel comfortable in dealing with these. The generic kind of pathway is either A, B, C, D, E, or as we have here, which is a more trauma-orientated guide, the C, A, B, C, D, E, with the C standing, of course, for catastrophic hemorrhage. This is more of a trauma situation, as the catastrophic hemorrhage would be the one to kill you before the airway. But generally, within ENT, it's generally airway, breathing, circulation are the ones that are most affected and the ones we take care of. But it's very important that you know a thorough assessment for assessment. Book yourself in for a trauma, advanced life support, or the generic advanced life supports. It's very important that you feel comfortable in dealing with these emergencies. And remember that when a patient comes in, they have to be seen by the appropriate team. It may be that a trauma patient comes in, does have a fractured nose and might be bleeding from their nose, but that doesn't change the fact that trauma needs to get involved if they've got, I don't know, bones sticking out of their buns. Get the anaesthetist involved, get the GI surgeons involved if it's trauma to the abdomen and they have some weird something in the ear. Make sure that they're seen by the appropriate team. ENT will sort out the ENT things, but you have to be aware of your limitations within our role. And again, always ask for help if needed or unsure. The seniors and other colleagues will be very accepting if you feel that you're unsure or you think help is needed for a very unwell patient. They will not hesitate, or they will not hold it against you if you ask for their advice or help. Always ask for help. So this is a more of a brainstorming slide where I'm going to ask you to think about what are the different emergencies. If you rack your brains, what kind of emergencies might you see would happen within the ear? Think about it. To be honest, not too many emergencies involving the ear, but one of the more common ones is a foreign body within the ear. This is a foreign body removed from the ear, and obviously that would be quite painful to have inside if it's alive and stinging. Now, emergencies of the nose. The bread and butter is epistaxis, but there are other emergencies. And if you think about what emergencies happen in the throat. Airway things you have to be quite aware of. Now, the first one is epistaxis, or a nosebleed. This is probably the bread and butter of our speciality when we get called to the emergency department. You can see 2 to 3 a day, sometimes more on a busy day, sometimes less on a less busy day. But this is what you'll be seeing quite often in the emergency department. It's very, very variable in presentation. Sometimes they can just have a very slight trickle and you don't need to worry anything. If they're hosing out of their body, blood out of their nose, then you need to make sure that you're treating them appropriately. If they've lost a lot of blood, you've got to activate the protocols of things. Get a senior involved, maybe if you need to transfuse blood, things like that. But be aware that it can be very variable. First of all, conservative measures. You want to put patient in a correct position and put pressure over the soft fleshy parts of the nose. Firm press. Tell the patient to put a timer for 15 minutes while leaning forward. They can sometimes do additional things like ice cubes, sucking on them, on their forehead or the back of the throat, put ice cubes there. But time and pressure will stop most nosebleeds. Obviously get the patient to spit out any blood, because you don't want them to swallow that, because that can give them some nausea, and they're already feeling unwell. You don't want to give them that as well. Then once you've kind of tried with conservative measures, you want to actually have a look, see where you can see where it's bleeding from. The nose here is very vascular. You can see there's lots of different arteries going in there. You've got an anatomical area called the Little's area, or Kesselbach's plexus. This is perhaps the most common place of a bleed that you see, definitely in the anterior bleeds. You can also have posterior bleeds, but they're generally a bit more rare, sometimes in the more elderly patients. But for the most part, I would say around 70% of the bleeds that I see are kind of in this area here, which can be visualized quite well. You want to make sure you're able to visualize it, so make sure to clean out the nose of any kind of large clots or anything like that, if they're obviously in the way and causing the patient distress. What I like to do is get some cotton wool, soak it in some local anesthetic and adrenaline, and kind of put that in the nose. Warn the patient that it doesn't taste very nice, because that's always a bit of a shock for them. It will numb the nose, it will decongest the nose, and it will also thin any blood vessels, which makes your job a bit easier when you go to cauterize it. We generally use silver nitrate sticks when we're cauterizing. Avoid cauterizing in too large an area or both sides of the septum. These can kind of increase the risk of a perforation between the septum, so try and do one side only rather than both sides if you can get away with it. If that's not controlling the bleed, then the next escalation is to pack the pressure. When you have a bleeding wound, you put pressure on it. It's a bit difficult in the nose, so we have to put either what we call a rapid rhino or a tampon. The rapid rhino is basically a large balloon, or a small balloon that we put in the nose and can fill up. A tampon is, as the name suggests, a tampon that goes in there and swells up as it soaks the blood. Ensure the patient has appropriate analgesia, because these are not pleasant to go in and they're not pleasant to have in either. These will generally stay in for a while. Hopefully this will stop the bleeds in most part. Again, additional things that you might want to do is some ice, sucking on the ice cubes or the back of the throat or the top of the head. You might consider some topical tranexamic acid, or using Flow Seal instead. That's a bit more advanced. I don't particularly use that in the day-to-day, but those are things to consider. Then you might think to yourself, oh dear, my patient is still bleeding despite all this. The first thing you want to do is have a look at your patient. Are they appropriately packed? This patient is not appropriately packed. She's got what we call walrus teeth that are coming out from her nose. These packs aren't in the nose and they aren't stopping the bleeding, so they're not doing what they need to be doing. So they just need to come out, and you want to try and pack them appropriately, and because that's not going to do anything for her bleeding. If you're worried that the patient's still bleeding despite packing, it might be a good idea to inform your senior and remember the ABCD protocol. Do you need to be thinking about airway? Do you need to think about breathing circulation? All that. You have to make sure you run that at all times as appropriate. You want to get IV access. You might want to do their bloods as well. A hemoglobin to check how much they've lost. You can do that. You can check a VBG, check that on the VBG as well if you want that a bit more quicker. Group and save or cross-match depending on how much they're bleeding in case you need to transfuse them. And it's also a good idea to look at their clotting. Is their INR really high because they're on warfarin? Do they have any other kind of coagulable states? You might want to consider if their INR is super high, like 8, that you might want to give them some vitamin K, reverse the anticoagulation, or if their blood pressure is through the roof, it might be worth giving something to bring that down. But do be aware that giving patients amlodipine and starting them on that in an A&E setting isn't the most appropriate time to start blood pressure medication in the long term. What you can do if they're packed and they're still bleeding, you can increase the air in the balloon. Sometimes they just need a couple more mils, sometimes 5 mils, sometimes a little bit more in the balloon pack, and that can, just a little bit extra pressure from inside can stop that bleeding. Additionally, if you're struggling, you might also consider packing the contralateral nose to put even more pressure on. Sometimes this is needed. Be aware it's very painful for the patient, so try and avoid it if you can. You can also consider, if you've just got a very kind of anterior pack, or you don't think the tampon is in the best position, you can change to a posterior rapid rhino, which is a longer one, which has 2 balloons which can go a bit deeper in. So if you're worried about posterior bleed, it might be worth starting with a posterior rapid rhino, because it's bigger, goes deeper in, and might stop the bleeding if it's a bit further back that the anterior might struggle to do. Be aware that's also very painful, so don't, if you can avoid it, do. Then we get to the kind of third line almost with posterior packing. This is where you use a variety of methods. You can use a Foley's catheter, you can put that down the nose, fill it up, pull it back, and put BIP dressing in. This is a bit more advanced. I'm not going to cover it in too much detail. That might be a I'll cover that a bit more in the Epistaxis lecture that's coming up. But that's a bit more advanced. That's generally when you'd want your reg calling in, and they might need to do that. So as I said, get the seniors involved if you're worried, and if you're thinking this isn't stopping, I can't do anything, make the patient nil by mouth. If worse goes to worse, they might need to go to theatre, so you need to make sure you've got everything prepped just in case. Then the next one is Stridor. Here are a couple of links. I've shared them earlier, and I'll share them again once I send out the feedbacks for this presentation. But you can type this up. This looks at Stridor in the, sounds a bit different from child and adult, but Stridor is an emergency that you have to take very seriously. It is the A of the ABC, and it's quite important. So what is Stridor? Stridor is a large, harsh, high-pitched respiratory sound. When you hear it, you should be worried, because patients, when they have it, they can get sick, and they can get sick both quick and really unwell. It's a bad sign, but when you've got these other signs of, if they've got some dysphagia, that's rapid onset. If they've got some voice change, that's rapid onset. Or if they're systemically very unwell, that should bring your alarm bells thinking, I should get my senior to see this patient soon as possible, because you're worried that they might deteriorate, and they might deteriorate rapidly. And then you think to yourself, you're called to see this patient in A&E, and you think, oh bother, my patient has Stridor. You've identified they have Stridor. What do? You see this patient immediately. You stop doing the kind of cannula that the nurses have asked you to do. You don't rewrite the drug chart. You go to A&E there. You involve the senior. You get your team aware and involve them, saying, I'm going to A&E to see a patient with Stridor. Would you want to come? I feel comfortable in the initial assessment. I'll contact you afterwards, or if you're not comfortable, ask them if they want to join. They might be busy in theatre, so it might be appropriate for you to review initially and see how bad it is, but make sure they're aware at the very least. So you go into, the patient will generally be in the resus if they've got quite bad Stridor. If not, you want to get them to a higher care kind of facility of A&E. This isn't a patient appropriate for the waiting room. This isn't the patient appropriate for minors. You need to notify that this is a potential airway, and A&E generally are quite good at getting you the things you need. You want to make sure there's a crash trolley nearby. Generally is if it's an A&E, but if it's a ward setting, you want that nearby. Not always. Generally, most of the patients I've seen with Stridor have more been stable. They didn't need anything, but you need to make sure that you have the equipment, if you do need it, nearby. And you also want to monitor, so you want to see what their SATs are doing. You want to see what the heart rate is doing. But the most important thing is to not panic. Don't panic. You have to kind of stay calm, encourage the patient to sit right, make it more easier for them to breathe. Panic is what the patient's doing, and what you have to encourage them not to do. They're going to be in hospital. It's a scary situation. They're not able to breathe properly. They're sounding like Darth Vader. What you have to do is kind of exude an air of calm, of professionalism. You want to kind of show that you know what you're doing. Don't worry, it's going to be all right, and you're here to sort it out. Because if you start panicking, then they'll panic even more and makes things worse. So the first kind of things is high flow oxygen, adrenaline nebs, 1 ml, 1 in 1,000. that will help kind of with the with things. IV access and blood gas would be useful only if tolerated. If this is going to agitate the patient a lot, if they're on that kind of balance, then I would kind of avoid that. If they're past that kind of threshold and are deteriorating a lot, then you'd put it in straight away. You can give the patient high-dose steroids. Lots of different departments and hospitals use different things. I think for my local team, I think we use dexamethasone IV. And while you kind of got this baseline things, you need to try and investigate the cause. What could be going on? Take a history, do an examination. All kind of keeping an eye on the patient, making sure that they're doing so well. Is this something that's been going on for 5 years? Is this something that's been going on since this morning? Did it happen after did they have any trauma before? Was it after a medication they took? Try and find out what's been going on. And then you might think to yourself, you've done all that, but you realize, oh dear, my patient has a compromised airway. And then you need to think to yourself, oh, I need to get help here. Airway, most important thing. You need to get help, and you need to get the help quick. You yell it out if you're in the corridor. You need to make sure that alert is called out and you have some help in assessing this patient. A, B, C, D, E, airway, breathing, circulation. You want to run this protocol. The first line to establish the airway is an endotracheal intubation. That's the first line, even if they do have a swollen epiglottis. If we can get a tube down them, that's a safe airway, and then we're quite happy with that. If we can't intubate and we can't ventilate, then you would want to go for a front of neck airway. And these are you can do an open scalpel bougie or a needle. This is quite advanced, and it's something that you would be expected to do as a new F1 or new F2 or an SHO on the ward. But it's good to know about, and there's some very good YouTube videos showing how to do these in a pinch. But this is generally, hopefully your reg would have arrived in A&E and they can start doing about these. Ideally, if you'd want to put in a trachea or something, that could be done in a more controlled area in theatre, if intubation isn't appropriate. But these would be the emergency options. So epiglottitis is one of the causes of stridor, and when you look at this, which one of these is the unsafe airway? Yeah, so I'm getting a lot of B's, but it's in fact a trick question because they are both safe airways, or more secured airways really, because this is what you might expect to normally see when you're looking down with a nasal endoscope. You can see the air is going to get in freely, the vocal cords are all very nice, it's not swollen here at the top. Whereas this one, it's a safe airway because we've got a tube down and we're able to ventilate them through that tube. Would it be unsafe if it didn't have that, because you can see how swollen and angry that is. That's not a very happy epiglottis. They're going to have difficulty breathing through that. Now, traditionally you have the 3 Ds of epiglottitis: drooling, dysphagia, and distress. Again, distress, you need to remember not to panic them. They generally come in with a history of a kind of worsening sore throat. It'd be tender or neck palpation. They'll have dysphagia, hoarseness, and at the worst, they'll start having stridor. In the past, it used to be known as more of a child's disease. However, with the new vaccinations, we're able to kind of prevent a lot of the childhood epiglottitis, and now the mean age for the disease is around 55. So ways to confirm: first of all, it's clinically. If you have an endoscope and you feel comfortable using it, nasal endoscopy can be used to diagnose it. Theoretically, you could get an X-ray and that might show a thumbprint sign. However, if you're thinking epiglottitis, you're thinking airway, you don't have time for them to go all the way to X-ray and get an X-ray of their neck. That's more of an exam question. It's not appropriate in the kind of emergency setting. Again, A, B, C, D, E, you want to make sure their airway is okay, you get seniors involved, you keep the patient nil by mouth in case you need to take them to theatre. Again, you treat them with IV antibiotics, IV steroids, adrenaline nebs, humidified oxygen, IV fluids, and again, try not to stress them out. That's the immediate management. Now, another emergency that we don't see so much anymore because tonsillectomies have decreased due to COVID, but a common emergency that you might see is a post-tonsilectomy bleed. Now, if you look at the back of the throat, when I saw this image for the first time, I thought, wow, it looks really, really infected. You can see all this white area here at the back. You can obviously see the bleeding areas where the patient is bleeding from. This is emergency. They can bleed a lot from there. However, this white area that you can see isn't that abnormal. That's kind of a bit more kind of normal post-operative change. It will look really grotty when you look at the back of tonsillectomy patients. It's not very pleasant things, but the thing you need to look out for more than that is that bleeding there. They can bleed a lot from there and they can get very sick. You need to take it seriously and you need to get the seniors involved promptly. There are generally two types of post-tonsillectomy bleeds. They fall in the primary, within 24 hours, or secondary, which generally happens in the 5 to 9 days post-op. Again, A, B, C, D, E. Airway, get the patient to sit up, spit out the blood, suction any blood that's kind of there, see if you can see where it's bleeding from. You want to get IV access and blood for this patient. Again, full blood count, clotting, group and save, or cross match. Depending on that, you need to transfuse them if their HB is dropping too low. Keep the patient nil by mouth, and through the veins, through the IV access, you can give them fluids, you can give them pain relief, and you can give them some tranexamic acid as well, in an attempt to kind of control the things. If it's not that heavily bleeding and doesn't need to go to theatre immediately, generally you can manage these patients with kind of more conservative measures, medical management, such as hydrogen peroxide gargles, ice packs, and kind of keeping an eye on them as they're doing. But if you're unlucky, you might think to yourself, holy cow, this patient's actually heavily bleeding. So again, A, B, C, D, E. The important one here is the C, but also the A, because where they're bleeding from. The bleeding might obscure that airway. You need to call the on-call ENT seniors, get them involved. You also need to make the anaesthetic team aware. People who are bleeding from their tonsils, obviously a bit more difficult to intubate as well, so they may need to escalate to their seniors and get their consultant to come in if they need to intubate this patient overnight. You want to make sure that you have everything prepped for theatre, that all the forms are done, that the theatre coordinator is aware, that you have everything sorted so everything's a smooth transition there. Again, tranexamic acid, if appropriate and if you're confident, you can consider using direct pressure. Getting a gauze soaked with some adrenaline, pressing on it on the bleeding point with some Miguel forceps. Only do this if you're secure with your hand skills, that you know you're not going to drop that down, because you don't want a gauze stuck in their throat when they're bleeding out heavily. And you want to put pressure on there. Sometimes that can stop that with the adrenaline and the pressure. However, only do that if you're confident. Again, another concept within post-tonsillectomy bleeds is herald bleeds. It may be that the first bleed that they have is a herald bleed, so they would have the first bleed, and then a little bit later throughout the day they might get an even worse bleed. The second bleed would generally be the worst bleed in these herald bleed situations. So when they do come in with a bleed, you need to admit them for at least 24 hours observation. Some centres do it for a little bit less, but some do it for a little bit longer. Now moving on to foreign bodies, which is the other bread and butter, especially with the younger patients. Generally, in the emergency setting, nose comes before ears, generally because of the risk of aspiration. If somebody has a bead in their ear, it's not particularly going to go anywhere, but if they've got a big bead in their nose, it might go down and kind of go down the wrong tube if they attempt to swallow it. Now the ones that are urgent that you need to see and get out straight away would be batteries, in particular button batteries, magnets, live creatures like the picture of the wasp I shown earlier. With the live creatures, get the ear full of olive oil to drown the creature. You don't want it alive in the ear kind of thrashing around and causing more damage. Olive oil is a good way to drown them. Semi-urgent, if it's a sharp object or an object that might swell, then it might be useful to, that's generally some food things, I think sometimes corn can swell up, that they need to be seen in a prompt setting. So don't postpone them for too long. But most things can be seen in a reasonable prompt setting in the kind of clinic setting. Put them on the emergency clinic for the next day or in a couple of days' time. Generally, it's not the biggest thing. What's important though is to use the correct tool for the job. What you don't want to do is to push the object further back in. So we've got lots of different toys here in ENT. Here we have showing that you can go behind and pull it back rather than trying to clip it at the front and pull it in. Other things is that you can try in the emergency department is get the parent, if it's a child, to do a mother's kiss, to kind of get them to make a seal over the mouth, cover the unaffected nostril, and get them to blow in to hopefully get the air pressure to go out of the nose where the foreign object is. You can recreate this sometimes in A&E with a bag valve mask. This is actually quite a good image and a good video on YouTube. I'll post the source as well there, where you can see they put a puff of air in through there and then out comes a plastic thing from her nostril. Once you remove the foreign body, always check for a second one. The amount of times where I take out something from their ear and there's a second one hiding underneath it that you might have missed if you didn't check again, I've lost count. So it's important because children who put stuff in their ear have a high chance of having had stuff in their ear before. And remember, with the children, sometimes you only get one shot, and only do it if you're confident with these younger ones, because they won't particularly want you to mess around with their ears or nose for too much. So involve the seniors. What's that? If it's something that you can't get out, or the child isn't tolerating, or the adult isn't tolerating sometimes, then you may need to take them to theatre, so you need to prep the theatre. Generally not an emergency. This doesn't need to be done overnight for the most part. Now another emergency affecting the ears this time is what we call a Peri-auricular Haematoma. This is an emergency in the way where you've got a blood clot kind of collecting within the pinna here. The reason why this is an emergency is if this isn't treated, then you get a cauliflower ear, because the blood supply to this cartilage here isn't going to happen. So sometimes you can do a needle aspiration, sometimes you can get away with or sometimes you might need to put a scalpel and try and drain it out. So that there, and then put some pressure on to kind of put it on there, and then you kind of review them in a couple of days' time. And this is the ear after a couple of days. Now for the third bread and butter of ENT would probably be tonsillitis or Quinsies. Quinsies are referred quite commonly, but I'd say generally only a third of those referred to A&E are actually true Quinsies. A lot of them are kind of severe tonsillitis. Remember that a Quinsy is not an abscess from the tonsil, it's a peritonsillar abscess, and you should be more looking a bit more kind of laterally than the tonsil itself. Most tonsillitis in the community, the vast majority are seen by GPs. And the biggest challenge in that setting is kind of patient education, saying that they don't need antibiotics for a mild tonsillitis. So as much as we complain about how much tonsillitis we have to see, the GPs see multiple times more. Generally, we perform what we call a Portsmouth protocol at our local hospital, which is a combination of IV fluids, IV antibiotics, and IV steroids. We use dexamethasone. Control. If you're worried about a quinsy, you can attempt aspiration or incision and drainage to get that pus out of there. Where you'd want to try things there, I'm not going to go into too much depth in this presentation. I'll save that for the kind of throat quinsy presentation when I get to it. We generally try and avoid it as much as possible these days due to COVID, but get your seniors involved and find out what the local protocol is. Sometimes just trial of IV antibiotics is beneficial than attempting aspiration, given the risk. Again, make sure the patient has adequate analgesia. One of the main complications of tonsillitis and quinsies is the fact that they're not eating and drinking. Getting them eating and drinking is the most important thing to getting them home. Because if they can eat and drink, they can stay hydrated at home, and they can also take their tablet antibiotics at home, and then time will do the rest. Also remember, in these patients, when you're taking bloods to check the white cells and things, add on a glandular fever screen. You can book outpatient appointments if you're worried about a quinsy and it's COVID time and you didn't do the aspiration, so you can follow them out in an outpatient setting. Now this is the getting towards the end, so this is the quick fire round. These are some very subtle images that I want you guys to all to think about a little bit and say, is this, or is this, what could this emergency be? Now it's very, very difficult, so put on your thinking hats. So what emergency is this? Yeah, so neck trauma, obviously stabbings, not as common as where I work at the moment. I was previously working up in Birmingham, and there it's a bit more common. But knife trauma, you want to get the seniors involved, you want to get the trauma team involved. If you're worried about the vascular, sometimes you need the vascular team as well. If you're worried about the vascular team, then that's what we kind of deal. Mainly we deal with facial trauma and suturing, like lacerations and things. That's more normal. Again, this patient, what's the subtle ENT sign here? Yeah, so you're worried about angioedema, Ludwig's edema, not true ENT, but swelling of that area. You're worried about the airway. Again, what's the subtle sign here? Big red, angry, shiny. Looks like there's a big infection there that's a bit deeper. These can be really serious. They can infect the airway, so you need to get them on IV antibiotics, get a senior to review. They may need incision and drainage, potentially in theatre with washout. Again, this is the various obvious pictures of mastoiditis, acute mastoiditis. We get lots of queries for mastoiditis. A lot of them aren't that clinically exciting. Something to be aware of. This is something we often see in the emergency department as well. Yeah, you can see facial nerve palsy, sometimes they come in with sensory hearing loss, kind of things to do with the cranial nerves. And this one, this is perhaps the most subtle of the ones, but you can see nasal fracture. With nasal fractures, make sure they don't have a septal haematoma, a collection of blood around the septum, and then generally see them in 7 to 10 days. I think you can make out the identity of this foreign body that the child has swollen. You can get kind of foreign bodies that are swollen, food boluses. This is sometimes, depending on where it is, might go between us and gastro. Gastro are generally quite good at dealing with the food boluses because they they do endoscopy a bit deeper down into the theatre so they can push it down, but sometimes we need to take them to theatre to retrieve the foreign bodies. Again, another subtle sign. You can have preorbital cellulitis, very nasty sinusitis. With the preorbital cellulitis, that's another emergency that you have to take seriously, because that involves the eye. You want to potentially get imaging to rule out any kind of abscesses. You want to get ophthalmology involved. And something that we see a lot of is kind of issues with the trachea tube. You can see this is perhaps a bit more of a fresh trachea, but you can see there's lots of kind of gunk there, so you might be asked to see a trachea tube that's blocked. So these might be something to read up about. Some of these topics are going to come up in future lectures though. Now just to round it off, if you're a medical student, which I think some of you are, try and make the most of your placements. You only get out what you put in. ENT is very hands-on, so feel free to ask to get stuck in there. We're all very happy to help people and let them learn new skills. ENTSHO.com, that's a very good resource if you're ever on call or shadowing anybody and you think, oh, I need to see a patient with sensorineural hearing loss or vertigo, then you look that up on that site. It's a nice Bible of reference to have, just to give you a big refresher of what you should do at your particular level. The SFO, which is I think the Student Foundation Ophthalmology, I could be mispronouncing that, but the ENT UK is basically the junior level of the ENT UK, and they're very, very good. They have some very cheap and very high quality teaching events and conferences, and it's very good. You might be able to present a poster there. Very, very good resource. Again, never underestimate the power of stickers. We deal with lots of small children doing our times, especially with the foreign bodies, and being able to bribe them with a dinosaur sticker or a shark sticker might let you be able to take that second chance of getting that that googly eye out of their nose. Also, another good resource is YouTube. Foreign body removals, they've got lots of good videos. Microsuction, lots of good videos. The different kind of front of neck airways, very good resource to consider. Thanks for stopping by for this lecture. It's going to be the first of a multiple series. I'll send out some of the ones that we're going to be doing later, some of the topic names, but if you have any suggestions for future ones, please let me know. I think I'm going to put this up on YouTube as well for reference, so feel free to leave any comments there. Again, can you feel free to fill out the feedback forms that I'm going to send out with SurveyMonkey. I'm going to put that in the description of the YouTube video if it goes up there as well. And thank you very much.